drug delivery, dosage, and procedures. When complete, students should be able to delineate the important aspects of drug delivery systems, summarize the different routes of administration common in the athletic training and pre-hospital healthcare settings, appreciate the advantages and disadvantages of common enteral and peri-enteral routes of administration, delineate the phases and disposition of oral drug delivery technology, differentiate between the variables in dosing regimens, and competently administer medications in the oral route to a patient. Pharmacotherapy is the treatment and prevention of illnesses and diseases by means of drugs of chemical and biological origins. The success of drug therapy is highly dependent on the choice of the drug product, and the design and dose of regimens. The choice of the drug is made by the prescriber after careful patient diagnosis and physical assessment of the patient. A prescriber may choose a drug product that may have an immediate release or a modified release and a dosage regimen. In the athletic training setting, the administration of a medication is common and an important aspect in the clinical procedure. Depending on the clinical setting, athletic trainers encounter situations where they will need to regularly administer prescriptions or over-the-counter medications. Although they may not use all routes of administration, should the situation arise, athletic trainers must be familiar with various drug delivery systems, including drug forms, drug dosing, and administration procedures. Some common routes of administration, as determined by the prescriber, include the enteral, also known as the gastrointestinal route, the peri-enteral, also known as via injections, inhalation, transdermal, and the topical route of administration. Drug delivery refers to the approaches, formulations, technology, and the systems for transporting a pharmacological compound to the body as needed to safely achieve its desired therapeutic effect. This is often approached via a drug's chemical formation, but may also involve medical devices or drug-device combination products. Drug delivery is an important consideration when administering medications in the athletic training clinic and integrates the following elements: drug dosage form, dosage regimens, drug release formation, and the route of administration. Biopharmaceutics links the physical and chemical properties of the drug and the drug product to their clinical performance in vivo. Thus, a primary concern in biopharmaceutics is the bioavailability of the drug. It is important to examine if the drug acts locally, such as a pill, or extravascular, such as affecting more of the systemic system. Biopharmaceutics balances the amount or the extent of the drug delivery. The routes of administration. Selecting the proper route of administration is an important consideration for prescribers. The route of drug administration is based on several factors, including the rate of drug absorption and the duration of the drug action. A drug's bioavailability is the proportion of administered drug that reaches the systemic circulation and is available for the distribution of the intended site of action. Drugs that are administered by direct intravenous injection are considered to have 100% bioavailability. Some drugs that are particularly well absorbed by the gastrointestinal mucosa may have bioavailability compared to that of an IV dose. However, most drugs do not have complete bioavailability by the oral route, so the dose administered orally is usually higher than one given peri-enterally. The route of administration and its dosage form, a tablet, capsule, or liquid, can clearly influence the bioavailability of the drug. This slide illustrates some common routes of extravascular and peri-enteral drug administration. Table 6.1 references detailed routes of drug administration. Enteral drug delivery. Enteral administration is a method of drug delivery that involves the GI tract. Administration of a drug by mouth is the most common, convenient, and economical method of drug administration in enteral delivery. Oral ingestion is the safest and simplest route, with several advantages and few disadvantages for the patient. Any drug that exhibits significant first-pass metabolism must be administered in a significant quantity to ensure that an effective concentration of the active drug exits the liver into the systemic circulation, from which it can reach the target organ. Since absorption of an oral drug involves the transport across membranes of the epithelial cells in the GI tract, this process is affected by the following: differences in the laminal pH of the GI tract, surface area per luminal volume, blood perfusion, presence of bile and mucus, the nature of the epithelial membranes, and the inactive prodrugs that require conversion by the liver to become active. Enteral routes of administration. Buccal, sublingual, and rectal modes are other options for enteral administration. Oral mucosa is highly vascularized and has thin epithelium that favors absorption of drugs. Therefore, a drug placed between the gums and the cheek for buccal administration or under the tongue, also known as sublingual administration, is retained longer and enhancing absorption. Even the rectal route has varying degrees of the first pass effect, contrasting with other routes of administration, where the drug is distributed in the body before reaching the liver. Both the sublingual and the buccal routes of absorption have several advantages, meaning that they are easily administered, rapidly absorbed, they bypass the harsh GI tract environment, and they avoid the first pass effect. Here is a table with some advantages and disadvantages of the enteral route of drug administration. Oral drug dosage forms. When prescribers select an oral route of administration, several factors must be considered that specifically relate to the transit time in the GI tract, which may vary considerably. Between patients and within an individual patient, with gastric transit time being the most variable. The state of the dosage form. Liquid dosage forms are emptied out by the stomach faster than solid dosage forms. And the fasted or fed state of the patient. Table 6.2 on the right illustrates some oral drug dosage forms, including tablets, solutions, suspensions, caplets, soft gels and gel caps, and even caplets. The phases of absorption of enteral medications. The rate of drug release from the product and the rate of extent of drug absorption are important for determining the onset, intensity, and the duration of drug actions. Systemic drug absorption from an oral drug product consists of the successive rate of phases. For most orally administered drugs, the site of action is the systemic circulation, and the drug must be absorbed to achieve the pharmacological response. Absorption of the oral medications involves at least 3 distinct phases: disintegration, or releasing the drug, or dissolution of the drug product in the body's fluids; permeation of the drug across the GI linings into the systemic circulation; and then disposition during GI transit, GI stability, motility, and metabolism. Modified release of drugs administered orally. Additional drug disposition may occur in the systemic circulation and thus reduce the concentration of the drug available to target tissues. By properly designing the drug product, oral delivery systems can vary the bioavailability of the drug that is active from rapid and complete absorption, slow sustained absorption, or virtually no absorption, depending on the therapeutic objective. Modifications in oral drug release profiles are used to improve the stability, safety, efficacy, and the therapeutic profile of the drugs. Drug release systems are classified according to the rate of release of the drug and the location of the release. Some examples of modified release systems are sustained release, delayed, extended, and controlled release. Sustained release are formulations in which there is no prolonged drug release over a period of time in a controlled manner. Delayed release, the drug is released at certain points after the initial administration. Extended release contains specialized coatings or ingredients that control the drug release, thereby allowing for slower absorption and prolonged duration of action to reduce dosing. Extended release formations can be dosed less frequently and may improve the patient compliance. Extended release formulations are advantageous for drugs with short half-lives. Controlled release, this form reduces dosing frequency for drugs with short elimination half-life and duration effects. It limits fluctuations in plasma drug concentrations, providing a more uniform therapeutic effect while minimizing adverse effects. Absorption rate is slowed by coating drug particles with wax or other water-insoluble materials, embedding the drug in a matrix that releases it slowly during transit through the GI tract, or complexing the drug with ion exchange resins. Most absorption in this form occurs in the large intestine. Crushing or otherwise disturbing a controlled release tablet or capsule can often be dangerous. Transdermal controlled release releases the drug for extended periods with consistent drug delivery over a certain length of time, sometimes for several days. Drugs for transdermal delivery must have a suitable skin penetration characteristics and high potency because of the penetration rate and the area of application are limited. Peri-enteral administration provides the most control over the dose of the drug delivered directly into the systemic circulation, cerebral spinal fluid, vascularized tissue, or some other tissue space. Drugs that are administered peri-enterally immediately overcome barriers that can limit the effectiveness of oral administered drugs. Prescribers use peri-enteral administration for drugs that are poorly absorbed from the GI tract or are unstable in the GI tract, such as insulin. The pre-hospital and emergency settings, peri-enteral administration is often used for patients who are unable to take oral administrations, such as unconscious patients, and in circumstances that require a rapid onset of actions, such as in emergency conditions. Peri-enteral administration of medication is associated with several potential disadvantages, however, including an increased risk of infection and the requirement for administration by a trained healthcare professional. The onset of action of peri-enteral administered drugs is often rapid, potentially resulting in increased toxicity when such drugs are administered too rapidly or in incorrect dosages. The dosage forms of peri-enteral drugs. Depending on the site of administration, sports medicine prescribers differentiate between intravenous, intramuscular, intraarticular, subcutaneous, intradermal, and epidural options. Other forms may include intraosseous, intraperitoneal, and intrathecal injections. For other routes of peri-enteral drug administration, the delivery systems can be aqueous, oily, or even solid, such as implants. Drugs can also be administered on the skin, such as transdermal administration, to enter the systemic circulation. Mostly, semi-solid dosage forms are used for transdermal delivery, including creams, ointments, gels, and pastes. However, liquid dosage forms, such as emulsions, and solid dosage forms, such as transdermal, controlled drug delivery systems, such as patches, can also be used. The direct introduction of a drug into the venous circulation or into the cerebrospinal fluid results in the drug having a quicker onset of its effects. Drugs administered extravascularly must be absorbed into the bloodstream and undergo the first-pass metabolism. This may decrease the bioavailability or fraction of the medication that enters the systemic circulation. The frequency of administration can be reduced by using the routes of administration that give a sustained rate of drug absorption. With drugs that are not very soluble, intramuscular injection generally provides a more rapid systemic absorption than orally administration does. The most frequently occurring adverse event of a lumbar epidural steroid injection is a post-dural puncture headache secondary to an invert lumbar dural puncture. When a spinal needle punctures the dural space, leaking cerebrospinal fluid causes a debilitating headache. This occurs in about 35% of epidural steroid injection patients. The risk ratio of a post-dural puncture headache is almost doubled when the conventional needle is used rather than an atraumatic needle. The patient will have an intense headache and a difficulty standing and will feel relief when lying down. Post-dural puncture headaches are resolved by administering autologous blood into the epidural space. Table 6.3 is the characteristics of common paraenteral routes of administration. Intravenous delivery permits a rapid effect and a maximal degree of control over the amount of drug delivered. When injected as a bolus, the full amount of drug is delivered to the patient. If administered as an IV infusion, the drug is delivered over a longer period of time, resulting in a lower peak plasma concentration, and with an increased duration of circulating drugs. With multiple dosing or with a continued infusion, the drug accumulates until the desired amount of administration per unit of time is equal to the amount eliminated per the unit of time, equalizing a steady state concentration. Intramuscular drug administration, the method of drug administration that provides the most consistent and greatest bioavailability, should be used to ensure the maximum therapeutic effect. Certain drugs are not suitable for intramuscular administration because of erratic drug release, pain, or even local irritation. Subcutaneous drug administrations. Like intramuscular injections, subcutaneous injections provide absorption via simple diffusion and are slower than with the intravenous route. Subcutaneous injections minimize the risk of hemolysis and thrombosis as associated with IV injections and may provide consistent, slow, and sustained effects. The incidence of adverse events secondary to injections of corticosteroids ranges from 2 to 10%, and these events can result in skin or fat atrophy at the injection site. The risk of tendon rupture secondary to corticosteroid injection in the soft tissue around the Achilles tendon or plantar fascia is less than 1%. Improper injection preparation can lead to infection, which in turn can lead to septic arthritis. However, careful sterile techniques and proper staff hygiene can reduce this risk. In addition, ultrasound-guided imaging enhances the accuracy of the exact injection site. Even without diagnostic imaging, 69 to 76% of the subacromial bursa injections are correctly injected, avoiding the unintended injection in the surrounding structures. Some drugs are intended for topical or local therapeutic action at the site of administration. Drugs intended for local activity are designed to have a direct pharmacodynamic action without affecting other body organs. Transdermal drug administration are absorbed from the skin, subcutaneous tissues directly into the blood. This route of administration is ideal for a drug that must be slowly and continuously administered over an extended period of time. There is no associated risk of infection, and the drug administration is simple and convenient. Absorption through the skin is a special challenge since one of the main functions of the skin is also to prevent particles or compounds from entering the body. A limited number of drugs have sufficiently high lipophilicity that passive diffusion across the skin is a viable route of administration. The success of transdermal nicotine, estrogen, and fentanyl patches demonstrates the utility of this route of administration. An example commonly used in the athletic training setting is the Lidoderm transdermal analgesic patch. Table 6.4 illustrates topical drug dosage forms. Medication drug dosing. Optimal medication dosing ensures that active drug is available at the site of the action for the correct time and duration. The ideal drug concentration level is in the therapeutic range. In the clinical practice, achieving the desired concentration of a drug is dependent on the dosing regimen that is based on the following: the drug delivery system used, the route administration, the frequency of the dosing, and the drug clearance rate. Factors that prescribers consider with medication dosing regimens include load dosing, maintenance dosing, duration of action, and dosing frequency. The goal is to sustain plasma concentrations in the therapeutic window. We do this by loading, maintenance, duration, dosing frequency, and the dosing interval. Loading, we need to consider the initial dose. We need to get the plasma to target concentrations. Maintenance, we need to keep a steady state concentration in the plasma. The duration is the time required to produce the desired effect. The dosing frequency, the greater frequency for a smaller dose. We may need a greater frequency for a smaller dose, and then the dosing interval. Depending on how often we're taking the drug, it may take a greater amount of time to maintain the concentration. Most oral preparations are taken by mouth, swallowed with fluid, and absorbed by the GI tract. Oral medications are available in solid forms, such as tablets, capsules, caplets, and enteric-coated tablets, and by liquid forms, such as syrups, elixirs, spirits, and even suspensions. For oral medication administration, the athletic trainer must be knowledgeable about the medication's purpose, its adverse effects, as well as patient preferences. When administering oral medications, we must consider: does the patient have any medication allergies? Enteric coating medication or extended release or sustained release medication should never be chewed, broken down, or crushed. Patients with altered GI function, such as a history of vomiting and nausea, should not be administered oral medications since they would not be able to retain them. And oral medications are contraindicated in patients who are unconscious, uncooperative, or unable to swallow due to medical problems. Should any issues arise, athletic trainers must be able to consult with a prescriber or a pharmacist to determine the best course of treatment for their patient. In summary, athletic trainers need to be familiar with various drug delivery, dosing, and administration routes. We need to review advantages and disadvantages of common administration routes and understand the limits of intral and para-intral medications. For para-intral, aseptic techniques must be maintained. Pain and anxiety are often associated with injections and are possible. In emergency situations, realize that a route other than oral administration may be preferred.